Welcome to the Explainer. I'm so thrilled to have you here today because, honestly, we're embarking on a truly fascinating spatial journey. We're going to dive deep into the anatomy of the breast. But look, we aren't just going to sit here and memorize dry textbook parts, okay? No way. We're going to deconstruct the breast layer by layer. We'll figure out its structure, its vital functions, and most importantly, the clinical reality of how this anatomy behaves in health and in disease. By the end of this explainer, you're going to see exactly how the surface features perfectly mirror the complex architecture hiding right beneath. So here is our roadmap for today. We're going to hit 1. Boundaries and surface landmarks. 2. Internal architecture and support. 3. The lymphatic highway. 4. A clinical focus on breast cancer. And finally, 5. Developmental anomalies. All right, kicking things off with Section 1, Boundaries and surface landmarks, mapping the coordinates. Now, you might picture the breast as just a simple, perfect hemisphere sitting on the chest, right? Well, actually, scratch that. It has this kind of hidden extension. Check out these terms. The axillary tail of Spence is this small, superlateral extension of the breast tissue that reaches up and outward. But it doesn't just chill on the surface. It literally pierces the deep fascia of the chest wall through a little opening called the foramen of Langer, extending right up into the axilla, the armpit. So why does this matter to us? Because a surprisingly high percentage of breast tumors occur right here in this hidden tail. Understanding this little structural quirk is absolutely crucial for any physical exam. So, if we're mapping out the primary coordinates, the breast sits squarely in the superficial fascia of the pectoral region. Vertically, it extends from the second rib all the way down to the sixth rib. Horizontally, it spans from the lateral border of the sternum right over to the mid-axillary line on your side. And of course, the key surface landmarks to orient ourselves are the areola, that's the pigmented skin containing sebaceous glands that literally lubricate the area, and the nipple itself. Moving right along to Section 2, Internal architecture and support, beneath the surface. Okay, let's dive under the skin. Here we see the two main functional divisions of the internal anatomy, the stroma and the parenchyma. Think of the stroma as the scaffolding and the padding. It's made up of connective tissue and fat, but its absolutely most vital structures are the suspensory ligaments of Cooper. These are fibrous septa that connect the overlying skin directly to the deep pectoral fascia. They essentially anchor the breast and maintain its protuberance. If these ligaments atrophy as we age, well, the breast naturally becomes more pendulous. Now, on the flip side, we have the parenchyma. This is the actual functional glandular tissue responsible for secreting milk to feed a newborn. To really visualize that parenchyma, consider this specific description right from our source. 15 to 20 lobes arranged in a radial fashion like the spokes of a wheel. Isn't that a great image? Each of these glandular lobes converges right toward the nipple. It is a highly organized delivery system. Every single lobe acts like its own separate little manufacturing plant, complete with its own duct system, carrying milk right to the center.
Next up, Section 3, the lymphatic highway, the transit system.
So if the parenchyma is the manufacturing plant, the lymphatics are for sure the transit system. And looking at this drainage breakdown, the most crucial takeaway is the sheer volume of fluid heading to one specific area. A massive 75% goes straight to the axillary nodes in the armpit. Another 20% drains medially toward the internal mammary nodes located right along the sternum. And the final 5% heads to the posterior intercostal nodes. Guys, this 75% majority is a massive clinical red flag. Because if a disease, like cancer, enters the lymphatic system, we know exactly where it's most likely to travel first. Notice the subareolar plexus of Sappi deep to the areola. This dense network drains a huge amount of lymph into those anterior axillary nodes. But what's really fascinating, and frankly quite dangerous, is how these systems communicate with each other. The superficial lymphatics of the breast actually cross the midline and communicate with the breast on the complete opposite side. This means a unilateral malignancy, a cancer on one side, can potentially spread and become bilateral. Furthermore, some lymph vessels from the lower medial quadrant actually communicate downward with the subperitoneal lymph plexus. This can literally carry cancer cells down into the abdomen, potentially depositing on the ovaries to create what's known as a Krukenberg's tumor. The interconnectivity here is just astounding. This brings us to Section 4, Clinical Focus, Breast Cancer. I want you to look at this number, 60%. That is a huge proportion.
Of all breast cancers, which typically arise from the epithelial cells of those lactiferous ducts we mentioned, 60% occur specifically in the upper lateral quadrant of the breast. Remember that axillary tail of Spence we talked about at the very beginning, that superolateral extension? Yeah, that sits right in this high-risk zone, making careful examination of the upper outer quadrant and the armpit absolutely critical. Which leads us to a really vital question. When a clinician examines a patient, how does all this underlying anatomy we just learned explain the actual physical symptoms of breast cancer? The signs aren't just random, they are direct mechanical consequences of the tumor interacting with the anatomy. Think of it like a puzzle. If a doctor feels a fixed immobile mass or sees the skin dimpling and retracting, why is that happening? It's because the tumor has infiltrated those suspensory ligaments of Cooper we discussed earlier. The ligaments are literally being pulled tight by the tumor, dragging the skin inward and anchoring the mass to the chest wall. What about a retracted nipple? Well, that occurs when the tumor infiltrates and causes fibrosis in those radiolactiferous ducts, pulling the nipple inward. And perhaps the most visually striking sign is peau d'orange, where the breast skin looks exactly like an orange peel. This happens when the tumor obstructs those superficial lymphatics we mapped out, causing fluid to build up and the skin to swell around the tiny hair follicles. Every single visual symptom is a direct physical clue to what is happening anatomically beneath the surface.
Finally, let's look at Section 5, Developmental Anomalies, Variations in Growth. These variations are so interesting because they tie directly back to our embryonic development. In the womb, mammals develop a milk line or ridge, and sometimes extra breast tissue or nipples just develop along this line. Polythelia refers to supernumerary or extra nipples. Believe it or not, these are incredibly common and are often just mistaken for simple moles. Polymastia is the much rarer development of an entire extra breast. We also see variations based on hormones. For instance, gynecomastia is the enlargement of breast tissue in males, typically triggered by hormonal imbalances right around puberty. And finally, a naturally retracted nipple can simply be a developmental failure of the nipple to push outward from the ectodermal pit. It's a completely benign condition, though it can make nursing a bit difficult and slightly increase the risk of minor infections. To wrap things up today, the biggest takeaway from our explainer is that anatomical knowledge truly, literally saves lives. Understanding the boundaries, the quadrants, and those critical lymphatic pathways is exactly why mammography and regular thorough self-examinations are so wildly effective. When you know what the normal architecture feels like, you can immediately spot when something structural, like a ligament or a duct, starts to change. So I'm going to leave you with this final thought. The next time you think about human anatomy, consider how the invisible scaffolding inside of us completely dictates the reality we see on the outside. Are you doing enough to monitor your own internal architecture? Thank you so much for joining me on this journey today, and keep learning.